the Planetary Health Working Group of Because Health, the platform who organized this meeting, and much more. We come back on this topic, inviting you all also to join the working group if it is of interest for you. So just some very simple housekeeping. I know that we are very used to do a lot of Zoom meeting, all of us, and I guess all participants, but just to remember that, first of all, we start recording the meeting. I hope it will be fine for everyone, so to be informed. There is also room for questions in the chat in your Zoom mode. And of course, we try to save time before the end of the meeting also for direct questions. So inviting you later to open the mic and to ask your question directly. The goal of today is really to explore what One Health and Planetary Health means in action at a different level, from university, research, at the policy level, and also on the field in action, in context. Is one of the questions that really we work on as a Planetary Health working group. As working group, we explore the One Health and the Planetary Health approach. And just for simplicity now, but then Nicolas, you can also help us to better understand the differences and overlapping. The idea anyway today is not really to go on theoretical side of the approach, but really to see how it reshapes our way of working. And working in health, in global health, and especially health in low and middle income countries and humanitarian settings is a very crucial question for us to understand what it means, how we change our way of working now that the knowledge is there and the evidence are growing in this direction. That's the main goal of today. I know that is a huge question, but we have 3 great speakers. I'm happy to introduce you Professor Nicolas Antoine-Moussiaux from University of Liège, expert in One Health, Dr. Francesco Maraglino from Ministry of Health in Italy, and Rhuna Khan, founder and executive director of Friendship NGOs based in Bangladesh, from 20 years working and developing. Hello.
Hello. Hello.
Thanks to be with us. We know we read a lot about your work since 20 years in developing bottom-up solution and natural-based solution to make health system resilient and sustainable in Bangladesh, one of the most unfair affected country by the climate crisis consequences. So it would be very nice to hear from all of you. I have the uncomfortable role of timekeeper. So sorry if at one moment I switch on again the video to remind that time is passing, just in order to listen from you all and also from the participant for questions. So welcome again. Without wasting any time more, I let Nicolas going into the topic, and thanks again. The floor is yours.
Okay, thank you very much. Well, I have the difficult work here to introduce a very vast topic that is One Health. So I will try just to fix some ideas. I propose to use some hexagons. So what has been asked to me or proposed to me is, well, to introduce indeed One Health, but also to make and to introduce the link or the gaps between research and action, and to talk finally about research, education, and action. So you might all know about One Health that is widely framed so as a connection between the animal health, human health, and environmental health. And mostly when we are dealing about One Health, we are dealing about issues, and most famous ones might be, well, in connection with animals and human, we have those zoonoses. We have naturally major challenges like climate change at the interface between the human and its or his impact on the environment. And finally, here at the intersection between animals and environment, I can pose the biodiversity collapse that is indeed a major challenge of our times. So if we take all these three challenges, finally, we can see that they belong to a wider set of, I will just move those. Okay, they belong to a wider set of challenges, and we can like go through those here: biodiversity collapse, climate change, and we can see that this climate change is, for example, tied naturally to vector-borne diseases. It's increasing health inequities. It's increasing also vulnerability. And that vulnerability is also tied to what we call neglected tropical diseases. And as you might have realized, it's not diseases that are neglected, but people. We have all that problem of re-emerging diseases with the risk of pandemics, and that antimicrobial resistance that is also tied to our use of the environment, hence also to matters of pollution and its impact on the, I would say, environmental welfare. And finally, a last one that I can collect here is that problem that we are facing of resource depletion. And all this is creating an interconnected net of problems, of issues. And that's the crisis that we are now facing. And that's why we use, or we need One Health, the One Health approach, that new stance. So coming back to our three elements, animal, environment, and human, I would like maybe not to talk here about problems, but also to talk about what is positive. And animals are bringing to human, well, work and help. Naturally, they are also contributing to our food balance, food security. Sorry, I am a bit annoyed by the videos here. Okay. And it's also important to our mental health. So you have all those companion animals, and that spirituality that is very important in our links to animals. Obviously, that mental health can be just replicated here for the link between human and environment. Food security, the same. It will be also be a link between, a positive link between human and their environment here. I include in that notion of environment any plant, any life, in fact, on Earth, but also naturally the quality of air and quality of water that are the famous ecosystem services that nature is indeed producing, and that we are benefiting from. And here at the interface between animal and environment, finally, considering this interface is forcing us to take another perspective on life. And this is what we call eco or biocentrism, that is opposed to anthropocentrism. So forcing us to take a different perspective on life. And so we might consider the welfare of animals and of any being on Earth for its own sake, with that notion of one welfare. And we could also finally talk about environmental justice, considering, I'd say, the responsibility that we have to protect the environment that has given rise to our humanity. So this is giving now a different net of possibilities. And I would like to show you how this can finally lead us to reconnect. Sorry, okay. To reconnect and to adopt a new mode of thinking. So if we consider here, sorry, again, I'm playing with the video of Zoom. If we consider here that link between animals and human, it's forcing us to think about that links, just as I told you considering the interface between animal environment leads us to adopt a diversity of perspectives, and that belonging, that sense of belonging of human in the environment, human to nature, is leading us to consider that embeddedness of things. And if we collect all these three notions of diversity of perspectives, embeddedness, and links, finally, we just might realize that those are the three components of what we call the system thinking. So finally, all that nets of problems and nets of positive relationship just invite us to adopt a new mode of thinking, that system thinking that is considering the links between the many elements that are constituting reality, but also the different levels of that reality, and the fact that at any level we might consider a whole that can be part of a bigger whole, and we as humans are part of indeed a wider whole. And the diversity of perspectives naturally going as far as trying to adopt some ecocentrism or biocentrism, but also more simply adopting different perspectives of different stakeholders and different actors across humanity. So this is for that new thinking. So I would like now to jump to what we have called that link between science and practice, and trying to think about that. I think that what is really tightly connected to One Health thinking might be those kind of sciences that are now rising, called implementation science and sustainability science. And both are tightly connected to One Health, indeed, in that they are action-oriented knowledge and production of knowledge that are indeed tightly binding science and practice. So in fact, we have those gaps between science and practice mostly, but many threads of science are trying to connect with practice and are promoting that link to practice. If we consider finally these two stance, the scientific stance and practice stance, it is finally inviting us to practice interdisciplinarity within science. This is a main motto in science, actually. Currently, I mean, that that interdisciplinary would be the way forward, indeed, to create the new solutions that we need. Within practice, we'll talk more about connections and cooperation. This is what we need, but finally can see that those are two flips of the same coin. It's just collaboration in different realms. Let's now consider the connections between these concepts. I would propose that, sorry again, I would propose to consider here that interdisciplinarity, action-oriented science that is really oriented towards that implementations entails a sense of responsibility of those scientists. I can also propose that interdisciplinarity is, in fact, the goal of it is to produce new solutions. So it's to develop creativity. So that is really what that sustainability science and interdisciplinarity for me is about. If we are now looking at the practice side of that graph, I would propose that sustainability science in connection, so and with practice, invites us to get committed truly. And finally, the fact that we have to connect to other actors and to reinvent our practices invite us to adopt a reflective practice. So the proposal here is, in fact, that all these, so that creativity and open-mindedness is in fact tightly related to the system thinking that I told is really important to us currently. So it means that creativity is needed to imagine the different links and the different perspectives. If we consider the fact that we have to adopt different perspectives and have that sense of embeddedness, we are now so considering the centrality of that reflexive practice. And again, finally, here between the links and embeddedness, it's getting that sense of relationship with, well, other stakeholders, with humanity, with nature as a whole. And this is entailing, so for us, a true responsibility, a commitment. So finally, all this to introduce a bit the topic that we will discuss, and to just as a conclusion, I would say that these blue hexagons that you see here, to me, are the true goals and responsibilities of education right now. We have to train new practitioners that would have all those qualities: creativity, open-mindedness, ability for reflexive practice, but also to get a commitment and a sense of responsibility. This means that the notion of values also must be more central in our teaching. Let's now get truly the final word, just to stress the fact that, in fact, nobody knows how exactly the problem will happen, and we don't know really what needs to be done. So we need to invent new practices, new teaching, and since nobody knows what finally has to be taught, we had to invent together in close collaboration between academics and practitioners the new ways really to work, to collaborate, and to create the knowledge that will be needed to feed that new practices. So thank you very much. I think I just consumed my time.
Thank you very much. It's for setting the scene and for presenting such a dynamic model. It's really helped us to understand that complexity. And now it's perfect to jump to the field directly with a slight change in the order of the agenda. Sorry for that. But it's a perfect link to jump to the field and to the experience in Bangladesh, where this complexity has a real and dramatic impact, first of all, but where also an organization like Friendship are responding with creativity, as you say, responsibility and commitment. So those concepts in action. So I think it's really interesting now to let the floor to Dr. Rhuna Khan. I think the idea is starting with sharing a video. So maybe Magali, if you can do that, and I let the floor after to Rhuna. Thank you. We don't have sound. That's often a problem with the reshared video.
You have sound? No?
No. Yes, maybe Tanzil from Friendship could share it. Let's So if you can stop sharing the screen. Now it works.
Healthcare services in the hard-to-reach and remote areas over the last 20 years, which was actually a need-based healthcare services for the communities. Friendship developed a 3-tier healthcare system. Tier 1, which is the ships, which act as a referral hospital.
আমরা যখন স্টার্ট করলাম কিছু অসুখ বিসুখ যেটা চিন্তাই করা যায় না যে এত ছিল, খুব বেশি হাইজিন মেইনটেইন করতো না, যার জন্য স্কিন ডিজিজ ছিল অনেক, স্ক্যাবিস, প্রচুর স্ক্যাবিস ছিল, একজনের হয়তো ফুল ফ্যামিলিতে হয়ে যায়। এর পাশাপাশি চোখের প্রচুর পেশেন্ট পেলাম আমরা, কিন্তু আমাদের চোখের ইউনিট ছিল না, আমাদের দাঁতের কোনো ইউনিট ছিল না। তো এগুলো সব কিন্তু নিড বেসড গড়ে উঠছে। আমাদের শিপটার মুভমেন্ট হয়, আমরা এক জায়গায় 2-2.5 মাস থাকি, দেন আরেকটা জায়গায় যাই। অনেক মানুষ কিন্তু অপেক্ষা করে কবে জাহাজটা আসবে, আমরা ওইখানেই অপারেশনটা করব। এই যে মানুষের যে আমাদের প্রতি ফেইথটা কিন্তু তাদের অনেক বেশি আমাদের, এবং তারা এমনভাবে মোটিভেটেড এবং কাউন্সিল নিজেদের দ্বারাই হয়ে গেছে যে না, আমাদের এই জাহাজটা হলো আমাদের জন্য এক ধরনের আশীর্বাদ।
Friendship started 20 years ago in the riverine areas of north of Bangladesh, because that was the need there. You know, we needed a floating infrastructure, which was a hospital, and as the land used to break continuously, we needed to take the hospital to the people, because so often the people could not come to any land-based units. Over 3 million services to maximize the capacity of our community health workers. We built a mobile app for mHealth that does household and individual registration, diagnosis, selects medicines to give, connects to our doctor center, and gives referral. It also includes a GPS tracking system for migratory families and patients.
আমাদের এলাকায় আগে বাচ্চাদের টিকা দিত না, এখন আমরা কাজ করা থেকে এখন বাচ্চার মায়েরাও আমাদের কাছে আসে, কোন দিন বাচ্চাকে টিকা দিব, কোন দিন ডাক্তার আসবে আমাকে একটু খবর দিয়ে। এখন স্যাটেলাইটে আসে 5 টাকার বিনিময়ে ওষুধ পায়, আমাদের কাছে আসে, আমাদের কাছে অল্প টাকা হলে ওষুধ পায়।
During the time of Sidr in 2007, you know, the coastal belt area was as deprived of health as in the northern region. So we thought here along the coastal belt, we could build a hospital. And I really wanted it to be a hospital which was for the people of this area. I really hope that in the coming 20 years, we see a responsible, quality, dependable healthcare system reaching people who cannot reach the system.
Thank you very much. Dr. Rhuna, the floor is yours. There was a problem with the line, I think. Hello, Dr. Rhuna, are you there? Do you hear us?
Hi, I think Rhuna is having a connection.
Okay.
Yes, I think I've got the connection, and I'm a bit worried that if I put on my face, you are going to miss the talk. So let me proceed without, and I will see if it's working well. Then I shall open the video. So I want to start by saying that, first of all, thank you very much Nicolas, for saying that, that I think the next step of academicians and scientists truly need to start working with field, people who are implementing. Now, I have a lot of respect for academicians and for scientists because they are the voice which is talking of tomorrow and what is going to happen. And also, they are the one element which has scientific truth about actually the results of work. Therefore, a lot of respect to them. But the point is, at the end of the day, you need to implement and show that whatever you're doing works, number one. It's simple enough to work in regions where people may not have the best of education, nor have the best of ability to be able to replicate. So it needs to be brought down to a level of simplicity, absolutely, which can be run by people who have not even passed high school. It's extremely important that this happens. Now, One Health is now something which people have realized because of the impact. Billions of dollars, according to World Bank, has been lost during. I don't want to go to figures. I've got all these figures written, but that's not the interest point. It's billions of dollars which have been affected by COVID. Billions of dollars which can be saved if we take into account that we need to work respectfully with the planet which is hosting all of us, which includes livestock, which includes the environment, plant life, and human. As soon as this disrespect and therefore non-understanding and invasion into each other's territory happens, an impact happens, which is not positive for anyone, none of us. So 20 years ago, when I started working, very honestly, I did not know about One Health, but I realized that it is impossible, totally impossible, to work without interlinking the environment and the environment, which is climatical, geographical environment. The rest I took as one unit. The plants, the animals, and human beings I had to take as one unit because they lived as one unit, and that's reality. You can inoculate all the cows against in the village, cows and goats against worms. The children are running around barefoot immediately. They are. You talk about a sanitation of washing, and you have to go to a river which is polluted for washing your hands. It's not going to work. We needed to work in bringing up the whole ecosystem, which today we call One Health. And what is this ecosystem? This ecosystem, and Nicolas, you brought up this element of justice. Justice is something which is not only climate justice. It is injustice which is happening in the world today. Injustice in terms of now we have this blame game. You do it, we are suffering, you pay, we have to. It's not this. It is a question of understanding deeply that human beings has to be dealt with at a level of equity, because the impact happens, be it 50 million climate migrants from Bangladesh, who is going to come in 2050 if it's not looked after. It's going to be invasive. Be it the 1 billion people by the end of the century, climate migrants, how are you going to deal with it? Be it the air pollution and the cost of the suffering of not only the human beings, but also the animals. We don't see birds anymore in most of our cities any longer. We see insects and mosquitoes coming up, and we're killing them with things which are totally invasive and bad for our own selves. So health, people in Bangladesh today are spending more than 67%, the poor and the ultra poor, more than 67% on basically trying to keep alive. Forget in health, forget about having an operation, basically to ensure that they can go to work the next day and they're not coughing and they're not having fever and they're not having pain. So it's the whole eco cycle, which is it's just so evident. And if it is evident, why isn't everybody doing it? What is the problem? Here is where the trouble comes in. Everybody thinks they know how to do it. Nobody wants to follow that. Nobody wants to understand that there is no panacea. Each country, each community, each
We lost you, Rhuna. Do you hear us? Sound is very bad. Can you not try again? There are some problems. Do you hear us?
I'm there. Okay.
Okay. Yes, please go ahead.
So as I was saying, just to continue, therefore, the solutions from between the donors to aid givers to the scientists and academicians, we need to work not in thinking that this is the solution we have found or this is the way to go about it, but in jointly cooperating and collaborating. If I have now a scientist or an academician or a doctor or a donor actually telling me exactly how to work in this environment, perhaps it won't work. You can't understand the context of how Bangladesh works between the government, between other organizations, stakeholders, and the poverty and the migration. So it is the same for everyone. If we can work and take from each other little parts, not whole, because panacea doesn't work, as I said, we need to ensure that there are some soft skills which actually for me are, I would name them the hard skills. It is not a question of a system. It is more a question of the way of working. Identifying the needs properly, identifying the tools which are possible in that environment, respecting the ecosystem of that particular area, country. There are more than 1 billion livestock in Bangladesh growing every year. And what is happening is people are still lacking just due to the sheer volume of people. We have 170 million people, the size of 1/4 of France, with 52% underwater. So the sheer pressure of the people, they need food, they need protein, they need nourishment. So we have to grow cows and literally grow livestock to keep this protein in the people, because we just don't have enough land and enough money to secure proteins in any other way. So, if you're not working with caring for your cows as if it's a family member, I'll tell you a little story, 2 little stories. One, in an environment when you have disasters striking, the cyclone strikes, and there is signal number 8 or 10, which is like really bad. People don't want to leave their homes because because they can't leave their cows behind, or the food which they have collected, over the year behind. So they are swept away by the tornado or the cyclone, but they don't want to leave the cows. So we need to come back and see how we can save the humans and the cows and the goats, not only the humans, because they won't come. And then there is this story, we have, Bangladesh is in the coastal belt of the Bay of Bengal. And because it has a river coming in, which is the, 3 or 4 of the biggest, there's the largest delta in the world. So we have all these Brahmaputra, the Ganges, the Meghna, and bringing silt all the time, hardly any rock. So the land is shifting all the time. And security-wise, the best is mangroves. Okay. After there's the front line of our defense.
Second line of our defense are the embankments, which due to management and, requirement of people to have more land is very often not maintained properly. Then we have the fields, and then we have the communities in 4 steps. People are cutting down the mangroves, cutting down the mangroves. So mangroves, water comes in, embankments are broken, the fields are all salt water. People start drinking salt water because there is nothing else to drink. And then you can understand what happens to a community. Mashkura, this woman, totally, she was a nice, bright young girl, beautiful, married, quite young. As you know, in Bangladesh, there's a lot of child marriages and all that. But anyway, she was married at 16 or 17, and she had 3 miscarriages. Now, it's a really a kind of an omen. If you are having a miscarriage and you don't have a child, and a mother-in-law, father-in-law, husband thinks that there is something wrong with you. And she was totally socially ostracized. Climate injustice comes in. Just look at her through no fault of hers. Then she came to our clinic. We have these desalination water plants, 6 or 7 of them in the coastal belt. So we started giving her free water. Her 4th child was a baby boy, born healthy and well. What was the cause of this years of social ostracism for her? If the clinic was not there, what would have happened to her? Drinking salt water, it is not only a question of no livelihood, it is also a question of total injustice. So, the mangroves needed to be there. In this context, I'm giving you an example of Bangladesh because that is where I work and I know this best. But in every environment, be it in Africa, be it wherever, be it in South America, these ecosystems need to survive. And the donor agencies, the scientists, the decision makers, academicians, all need to also understand deeply together in solidarity to be able to come up with a healthy world, for a healthy generation. And this is our responsibility because, as Greta kept talking about, it's not that we have not done anything. Al Gore was there, Charles was there, they were all speaking about it, about climate, etc., even in the 70s. But it is our responsibility to see it through. We don't see it through. And in spite of knowing, we need to, each one of us, have this commitment of working towards a solidarity of approach rather than individual approaches. So, thank you.
Thank you very much for sharing these examples and those stories and those witnessing from the front line of climate change impacting health in the real life of people, cross-cutting, of course, with other elements of vulnerability. Thanks a lot. And now continuing on the same line, but jumping of context, but the same line on how health, environment, and justice are shaping our policy, our health programs, and our health work. I let the floor to Dr. Francesco Maraglino from the Ministry of Health, Italy, to share from that perspective. You have 15 minutes too, so the floor is yours. Thanks. We see the presentation not yet in the full screen mode. We don't hear you. Dr. Marino, you're mute. Is still mute. We cannot hear.
Okay. Now
Okay.
Can you hear me? Okay.
Yes,
okay.
but we don't see the presentation anymore.
And now I will solve this problem.
Thank you.
Okay. Now you can see the presentation and also hear from
Yes.
me.
Yes,
Okay.
not in the full screen mode, but we see it.
Okay. Okay. Now. Okay. I think that is a full screen mode now or not?
Not yet.
I don't know why, but okay, I will try to go in another way. Oh, yes. No, it's not possible. Okay. So thank you very much again for inviting me. I have a lot of slides, but I will go very fast, I think. Can you see the second slide? I hope see. Yes. So
yes.
I will try to tell you about free experience of the One Health action and planning in my country, in Italy. And I will start with the experience that we have with antimicrobial resistant plants. These are plants that we started our experience to work in a One Health vision in some way with the first plan of antimicrobial resistance that was released in our country in 2017. And it was consistent with the WHO Global Action Plan. And we started adopting a partial One Health approach in which human health, animal health, and food safety worked together to release and to implement this plan. And the objective was to reduce the frequency of resistant infection, healthcare community acquired infection, and there were set some strategies, some action, and some realistic measurable target for the Italian scenario. And then we put in place a technical coordination group and 14 working groups with a multidisciplinary intersectoral mood to implement the plan. This is some of the national indicator and some of the results that we had in our country with the first plan. And for example, you can see here that we during the validity of the first plan, we had it was a reduction of the systemic antibiotic use in the community settings, so the healthcare in the territory, and also in the veterinary sector. This is the same for antibiotic and also for some specific kind of antibiotics. In particular, our colleague from the veterinary sector succeed on this reduction of the use of antibiotics because of the use of electronic prescription. That was a very, very successful tool for this. It was not in the same for the use of antibiotics in the hospital, because we at the beginning had a reduction of the use during the implementation of the plan, and when a new raising on the use in 2020 that was maybe possible linked to the use, not appropriate use of antibiotics during the first phase of the pandemic, COVID-19 pandemic. So we have a little slide with some examples of what I've said, but I've said already that we had a reduction of use antibacterial in the community, not a reduction in the hospital setting. And this is something that you can see in different slides that I will you will see, because I will leave the slide for reading. So this is something other national indicators and outcomes of the antimicrobial resistance, and in particular the prevalence of MRSA related from blood samples, the prevalence of CPA, but also some organizational indicators. It is very important to know that in Italy we have a regional healthcare system, so the regions are autonomous in the organization of the healthcare systems in their regions. So in some way, it's important for the Ministry of Health to know what is the situation in the different regions. And as you can say, not only all the regions, for example, it was not a success. They all the 21 regions had antimicrobial surveillance systems, but not all had the surveillance system for consumption of hydroalcoholic solution for hand hygiene in hospital. So it's something we had to implement. This is the surveillance of antimicrobial resistance. There is a set of the bacteria that are under the surveillance, and the flux of the surveillance is from the regions to the National Institute of Public Health, Istituto Superiore di Sanità, that has this mandate from the Ministry of Health. And all the data came through TESSI, that is the European Surveillance Systems managed by the European Center for Disease Control and Prevention, ECDC, and through the ECDC to WHO to the GLASS, that is the Global Antimicrobial Resistant EU Surveillance System. Another thing that I can say with with other slide is that for some of the pathogens we have different situation and different resistance in the different regions of Italy. So this is something on which we have to deal with when we go through the implementation of the plan. So very fast. We also work with human health, with veterinary health, animal health, but also with the food safety. We have all this human health, veterinary health, and animal health, and food safety in the same, all together in the same Ministry of Health, and also in the field and the territory at the local level, they are in the same department. So in some way, it helps practically in go with one health vision and one health action. And this is the results for the samples that are visited every year and are taken and for the research of pharmacological active substance and chemical contaminant in the different kind of samples that you can see here. So after the release of the old plan and after the implementation and also the analysis of this kind of results of the plan of critics situation on the plan, we worked on the new plan. And so this is the new plan that has been approved in November 2022, and so very recently. And in this plan, we in some way complete the One Health approach, including during the implementation of the old plan, but also during for the future of the validity of the new plan, the environmental sector, the agriculture sector, and the finance sector. So this is something that we in some way and the very important topic were about also the communication and transparency. I will go back on this in the next minutes. We also created a new, we are creating now a new coordination group, because there is the need of the steering group, a stronger steering group, for in consideration of the fragmentation of the healthcare system in other countries. So we will have the steering group with all the directors general involved and representative for the three macro area of the regions. And this is the main objective. I will go in particular, so something that are new and some way consistent to the previous speakers' insights, and is in particular to promote the innovation and research. So also working in One Health approach. So we do a research in which the human health and the animal health are together to strengthen the national international cooperation. Cooperation is another key word, but also to improve public awareness, to promote training of health professionals. So on one side, the education and the information and communication for the general public, that is in some way have to be strengthened to cooperate with the public health authorities in fighting antimicrobial resistance, and to promote the training on health professional in every time of their education, when we are graduating and also in postgraduate courses. So this is something that we will do. I will go very fast to all the numbers about the different actions, and someone I think talked about before about the simplicity of the messages, and we tried also in our plan to realize a catchy and easy to read version of the plan that will be this is for the general public. It will publish it on our website, the websites of the Ministry of Health in the next weeks. These are the different grouping rules, and another new indicator that we included in our plan is the pediatric consumption of antibiotics, because in Italy we have this pediatrics that are like general practitioner, but for the pediatric population, and there is some issues on the use of antibiotics, antibacterial in this kind of population. So we have to monitor them to solve some problems about this. Very fast, another example about the One Health approach is in a different plan. That is the plan of the National Strategic Operational Plan for Preparing and Response to the Influenza Pandemic. And so this is the key word is the fact that we are in a spillover environmental, because so in this plan, in the implementation in this plan and in the implementation of this plan, we create some networks that have a big role in the implementation of this plan and to work in the inter-pandemic, but also in the pandemic phases of the possible pandemic created by an influenza virus, flu virus. And in particular, we have a network of influenza pandemic preparedness. It's a big network in which all the General Directorate for Health, including the animal health, are represented. And it is a role in government of this kind of crisis. But we also had the national group of experts for the early detection of the circulation of influenza virus strains with zoonotic potential, and the national network of public health and veterinary laboratories. So we have the laboratories in the same network for this kind of purpose. And this is how they work together. This is a flow chart. If an international alert or a detection at the national level of virus with zoonotic potential, a risk assessment is made together by vet and human health experts in a way to assess the zoonotic potential. And if a zoonotic potential is being assessed, if there is the availability of data on human-to-human transmission, there is a scenario, the potential impact on the population and on the National Health Service and the activation of the contingency plan. So this is a way to work together between these different networks. And the third example, I go very fast because the time is not so much, is how we worked for the national plan against arbovirosis. This is some epidemiological and historical information about arbovirosis in our country. We had for West Nile disease in 1998 the first outbreak with confirmed cases in horses in Tuscany. And in 2008, we had the first 3 human cases in Emilia-Romagna, and then we had some cases during the different seasons and years. And this is the wild West Nile disease in Italy in 2022. So in particular, we have some outbreak in the north of our country. This is a publication on neurosurveillance about this that I invite you to read. and it's about what happened in Italy during 2022. And we also had some outbreak of chikungunya, the first in 2007 in Emilia-Romagna. And maybe the virus strain isolated from the human mosquitoes were part of the cluster of Indian virus strains, so there was a presumed index raised from India. But we listened again about chikungunya in our country in 2017, when we have a first outbreak in the Liège region, also in Rome, and then a secondary outbreak in Calabria, 100 cases. So this is during the years, Italy had updated its national response, surveillance, prevention, and response plan in our country, involving a change, including the different diseases. So started with Nile, then chikungunya, dengue, and Zika, and tick-borne disease, and so on, including progressively the role of the human health, veterinary health, but also the entomologist's role, that is very important. And then also using as an important tool some document from WHO about the surveillance of mosquito vectors, the manual of prevention, establish and control of mosquitoes of public health importance in the European region, and the surveillance, the new surveillance role and inclusion of this disease in the European surveillance, to this new plan 2020-25. That is a national plan for the prevention, surveillance, and response to arbovirosis, and this is a 6-year plan in which we included all of the diseases that I mentioned, and in which we have a very strong role of the human health, national health, animal health, and also the role of entomologists. And this is the way in which this plan is organized. So integration of arbovirosis prevention, surveillance, and response into the other policies, including the environmental policies, and then the prevention that includes risk communication, training, environmental measures, vector control measures, vaccination, and recommendation on the organizational point of view. Only an example, it is about the surveillance of West Nile and Lesotho viruses. We have surveillance of resident birds on target species, surveillance of wild-based specimen found dead, entomological surveillance, clinical surveillance in equide, surveillance of human cases. And a very important thing that are listed all the measures that have to be taken in the event of the positive results. So very practical for the people who work on the at the local level. And similar recommendations are for the surveillance also arbovirosis transmitted by virus chikungunya, dengue, and Zika, and tick-borne. Another important thing is the monitoring of the insecticide resistance. So in that way, we are linked to the previous topics of my presentation. So the resistance to biocides with larvae effect, and resistance to biocides with adulticide effect. So this is the conclusion. I will leave for the statement at the end of this webinar. So thank you very much indeed. Over from my side.
Thank you a lot, Dr. Maraglino, for bringing the public health perspective and how public health is reshaped by changing the environment at the global and local level. You know, the Planetary Health Working Group of Because Health, who is behind the scene in organizing this webinar and other initiatives, is really a space for connecting scholars, practitioners, students interested in One Health and planetary health, and really to translate that into action. And today we are doing one step forward. And exactly to promote this kind of transdisciplinary dialogue, I lend the floor again to Professor Antoine in order to really relaunch the debate among speakers, and I also invite participants to write their answer in the chat. Thank you.
Thank you very much for giving me the floor. So it's my honor indeed to ask some questions to our speakers. So dear Rhuna, well, you know, I'm personally admiring your work, and it was a true pleasure to hear your passion in describing your action. And indeed, it's fascinating to see how finally through practice, and as you mentioned, it's ignoring about any One Health concept, but just you went through all those links and all those connections through your practice and action, just to end up with such a comprehensive and well, efficient action in the field. So it's just fascinating and honor to have you with us. So thank you again.
Thank you very much.
Just to introduce my question here. You have told about finally the relationship with science as a production of knowledge, and then how it needs to be fitted to particular context and to be applicable and to be feasible. As you perfectly know, I'm personally much interested by education also at any level, so to primary level to continuous education for all professionals. And I know that friendship is also involved in education. So I would like maybe to ask you to have a few words about your view about the place and the role of education in your action, and in finally the future that you hope to see well to happen for Bangladesh.
Thank you very much, Nicolas. My internet is so bad today. I am so sorry. Somehow in Bangkok, it seems the internet is really difficult. So I will, that's why I'm not putting on the visual. Education is hope. You know, when you're living in an environment where it's just so difficult because people have no ability to hope because they don't see a future. Because they don't see it. Sorry, there was another question which had come up. You can just ask me that. I'll just, sorry about this. I'll just check the chat and I'll, how mHealth is key to the success in Bangladesh, how we develop the tools. Okay. Okay, Mr. Xavier, I will give a quick line on your mHealth also. So to come back to you, Antoine, you see, so education is when you ask a person who's migrated, who seems to have lost everything in their life, what is it that you need for ensuring that, you know, you can continue survival? And for that, they turn around to you and they say, it's education for our children. And in a climate, you know, where you can't even get a person who can read, write, do mathematics, thousands of people on an island where we could just sometimes get one or two people who can do that. Can you imagine the challenge that comes up with education? We needed to work with the government in a sense that we would use the government curriculum, because that was a kind of an easy curriculum for people to understand. We needed to touch at least one school in each of these islands. And, you know, things like we needed to be able to shift these schools from one place to another when the land starts breaking, and all the children would follow us. You know, kind of mobile schools. Teachers trained who were all below high school, not only to do primary schooling for the children, but the teacher training was our responsibility. You know, training those people who can hardly read and write, you know, not even pass their high school. And then ensure that they learn about internet connectivity, so that for the high school, we could do ICT learning. Because of course, no teacher is going to go and live there and nobody is going to go there and train the children, and teach the children. And there was no, the internet was extremely bad. In some places you don't have internet. So we had to pre-record these classes and start working. Then I thought that these children, in spite of having some of much higher and better results than the national average, I mean, for our primary level national examination, we have that in Bangladesh, we have 100% children who have passed, and over 99% of A's with these teachers. So we needed to ensure that for the high school, we had the best teachers and they would pre-record the classes and work. However, there are certain elements which I felt would be extremely important. We needed to work on those. One, their ability for survival. Two, that is understanding their environment and their ecosystem in which they live, the political ecosystem, the economic ecosystem, so that they are enabled to be able to take their lives in their hands and they migrate. And the most important of all, to learn that working with ethics has a value which is far beyond anything that you can learn academically, with the school curriculum that we had. So code of ethics is something which we work with extremely strongly, nurturing the human compassion, empathy, honesty, tolerance. And then I decided that it would be much better if we could not wait for tomorrow, but to jump into day after tomorrow. And we started I spoke to the French minister at that time of education, and we kind of agreed that we would do interconnectivity of the French lycées and the students who are migrating 4 times in their lifetime. And now this has become, it's quite a good and a big thing, because now we are having children from Switzerland, schools in Switzerland, Cambodia, joining us, and we want to carry it to South America, Africa, and so they learn from each other over the internet, the school connectivity program. So the schooling system is part of an empowerment system. If you are aware, you know how to deal with it. So that's, if there's anything else you want to ask, you can ask, but then otherwise I go to the mHealth question. Antoine, tell me, is it okay, or do you want me to say something else? Is there something else?
No, yes, it's perfectly okay to jump to that question, important question about mHealth. So please go.
Okay. Thank you very much. So mHealth is a tool which it was again, it was developed in a very funny way. Funny way meaning, in 2007, we had the 3-tier healthcare system, and we wanted to empower our community medic aides in a way where they could at least do the maximum that they're capable of doing. They are all, again, people who are below high school. And we kind of developed online, unicoded with 64 algorithms of person-based mHealth, not a center-based mHealth. So, and we would train the community medics so that they had enlistments of between 100 to 250 households registered with them, which they would go and check. There's GPS coding, there is follow-ups, there is, they could give the over-the-counter medicines. It was all like, for example, you had to put in the thermometer and the mHealth will not work for 1 minute. Otherwise you don't know the temperature. So, things like that. We didn't have we couldn't afford really the very smart system of just touching and getting your temperature. So you had to use a regular thermometer and things like that, all inbuilt. So you can actually diagnose. You can then, if it's something through question answers of yes, no, yes, no, yes, no, you can reach whether if it's, if you have a stomach ache, where they don't even know where's the stomach. So our community aid knows where's the stomach. And then they will say whether you have a fever, yes, no, whether you have this, yes, no, etc. And then either they dispense the medicine, or it is immediately connected to our health center, 24-hour health center, where there's a doctor who can understand what's happening, or if it's an emergency, it connects you through a GPS location to the immediate nearest hospital or center where you can go and get treatment, whether it's ours or it's the government. And we have done over 5 or 6 million services already. It's working now through one of our units. One of our algorithms is used by Prescriptech, which is an EU-funded project, and they have already started this in Uganda and Slovakia, and they say that it's just incredible. And that's just only for one, which is our cervical cancer. We have 64 algorithms. So I think it's something which can, I don't know, it's something, we are not really an organization which is looking as how to kind of make money on it. It's just how much services we can give. So we'd be very happy to work on this with all of you. Like, for example, in the Rohingya camps, there were 5 other mHealths which had come. Harvard professors and all had come down for mHealth. None of them worked. Ours worked perfectly. You know, it was just so simple. People forget that it needs to be simple.
Thank you very much. So, yeah, obviously the action of friendship is so rich that we could spend several hours more discussing about your action, and I would have thousands of questions to ask you more, but maybe it's time to give the floor to Dr. Maraglino for a few questions. Maybe I would like before that, maybe you can jump to the questions that are asked in the chat. I would like to ask you a more personal one. You have focused very interestingly on the importance of networks in the concretization of the One Health promise, I would say, but you also insisted on the barriers. So I would like, as a policymaker, practitioner, I would like to have your insights about the difficulty, but also the promise of those networks as a way to organize our action. What do you think about those networks as a way to make One Health happen?
Thank you very much for your question. First, before answering to your question, I want somebody in the chat asked me if I can share the presentation. Yes, of course. I send it to Davide so he can share the presentation with all the participants. And there is another question, but I answer to you, to yours. And yes, I think that the work in the networks is very important, because we experience that also if you have a One Health approach, the different sectors have usually a different point of view in respect of the same problem. So the same issue, the same problem, the same matter. So it is important that you have to let them work together in the same group in a coordinated way, so that you can do the right balance and the right integration between the different point of view on the same matter. And I think it's really important also to have this kind of network to create, I say, trust between the different sectors, and also to share some that are the best practice. I mentioned, for example, the good experience that our vets have with electronic prescription. So this is of antibiotics for veterinary use. So this is a very important tool, because it showed apparently a very good result, very good results. So for example, this is the best practice. Of course, network need coordination. So this is something that is will maybe say this at the end, but in a country like us, in which there is a fragmentation in some way, there is an autonomy at the regional level to work. So you have to duplicate the networks, I think, also on the regional and the local level. So this is important. I can, if you allow, I can also answer to the question of Mr. Xavier, who say, do you have any suggestion how to motivate the hospitals in Italy to follow suit with the fight against MAR? Very good questions. I think that the first thing is to improve the awareness of healthcare workers. So and this is something which the education is a key role, as a key role. In our plan, in the old one, the new one, with a more strong way, as I can say. We underlined the role of the education of healthcare workers in every moment of their education time. So before the graduate and the postgraduate education. In particular, in Italy, I think that this is all in Europe and maybe in the world, we have mandatory continuous education in medicine. This is something for all the healthcare workers, not only on the human sector, so that all healthcare workers are obliged to do some courses, some education during the year and during the period of 3 years. So we experienced, for example, that giving as a priority in this kind of education, the theme, the matter of the AMR and of healthcare associated infection is something that works in raising the awareness, because in some way they encourage the healthcare workers to make a piece, a relevant piece of their education, postgraduate education in this field. Another important thing is also the role of also the institutional communication, both for the general public and also for the healthcare workers who work in the hospital. We had a lot of opportunity when there are some WHO days of and hygiene, care safety, and so on. And we use at the ministerial level, but also some of the regions do the same, to create events, webinars with the participation of the minister himself sometimes, and about this kind of the event and this kind of topics. So this is something that we use. Thank you.
Thank you very much. Thank you very much for your answers and your insights. I think that time is running. Well, it was really, I think there is no better word finally than inspiring. It was truly inspiring to have those different viewpoints, different stance about One Health and how integration has to occur. So all the difference of speech also between the testimony of Rhuna and the one of you, Dr. Maraglino. It was truly inspiring, and that's finally what it is at stake. We have to learn to work together with or despite sometimes also these different stance that we have on the same topic and the different context in which we are working. So I feel really that exchange and that difference of stance is really a rich input for these webinars. So thank you very much, Davide, and naturally the whole Because Health platform with Magali for organizing this. It was truly inspiring. Thank you very much.
Thank you very much to all speakers and all participants. And I especially I want to thank all speakers because we tried to do this meeting in the past and we had different kind of problems. So it's great that finally we did it. We did it and it's very inspiring for the action that we have in this year. So it's a very good way to start this year. If I can conclude on some takeaways in terms of praxis that I heard today, I think that the education of health workforce, the antibiotic surveillance and reduction, and floating hospitals, among others that you mentioned, are really three pragmatic examples that help us to understand what it could mean according to the context, One Health and Planetary Health in action, and how health is changing. At the same time, what I heard is that one challenge is still to be solved somehow is this ongoing storytelling and vision of keeping all those factors and determinants of health together. And I think that we can conclude on that, remembering that, as I put in the chat, the Planetary Health Working Group is, in a very humble way, one of many opportunities to continue the discourse and to continue the storytelling and eventually and finally contributing to the overall planetary health and One Health narrative. So thanks a lot. And we keep in touch from the website of Because Health, where we hope to find new opportunities for exchange. Thank you, everyone.
Thank you. Bye-bye.
Bye. Take care.
Thank you very much. Bye-bye.
Bye. Thank you.